Well, good morning. It's lovely to be with you. I hope you've all got a nice cup of coffee and a croissant or something to keep you company. And what we're going to do now is spend an hour on what is titled the subtleties of aortic valve disease, of aortic valve replacement, the subtle differences between patients and what they need. We're going to start with a look at echo. So often echo is a preoperative diagnostic tool. And we're going to hear from Guy Lloyd about how we need to think, not just about the operation, but about the whole future of the patient and what we're going to commit them to by what we do at the time of surgery. We will then move on to Ruben Jagannathan from Belfast, and he's going to talk to us principally about sutureless valves, about the benefits that they have, about the best setting for them, and something about his own personal experience with them, which I know to be very good. And finally, we're going to move on to the subtleties of the patient. So we're not just saying this is a young patient mechanical. We're going to talk about individualizing treatment, individualizing the operation, the incision, the type of valve for a particular patient, and Gianluca Lucchesi will talk to us about that. So settle back, I hope you enjoy it, and I'm thoroughly looking forward to it.
Hello, and thank you very much for the invitation to speak at this symposium. I'm going to be talking about the importance of achieving a low gradient after aortic valve replacement. This is an area which arises in discussion and has done for many years, and it's an area which does tend to polarize opinion to some extent. My name's Guy Lloyd. I'm a consultant cardiologist and the director of cardiac diagnostics here at the Barts Heart Centre. These are my conflict of interests for information. Now, the relationship between valve area and valve gradients is complex, but it has been noted for many decades that the valve area achieved during aortic valve replacement does potentially push a patient into an area which would represent to some extent clinical aortic stenosis. And this was first noticed by Rahimtullah many years ago. And if you look at this graph, you can see that the valve area achieved during surgery does fall into this 1 to 2 centimeter squared area, which is conventionally aortic stenosis, and some of it below 1 centimeter squared. And the result of that is a pickup in the aortic valve gradient and ongoing obstruction. Furthermore, if you look at the valve area indexed, you can see that quite a number of patients still end up in this 0.6, 0.7, 0.8 area, which is associated with ongoing obstruction. And this results in this concept of patient prosthesis mismatch. So it's important to recognize that most valves are to some extent stenotic. And in a proportion of these patients, it will result in an elevated gradient. And in a proportion of these patients, it will result in an adverse outcome, either in terms of ongoing symptoms or in terms of issues relating to prognosis and cardiac events. The finding of a high gradient after an aortic valve replacement is not uncommon. And there are a variety of reasons why that should be. And these are briefly summarized on this slide. It can be because there are subvalvular issues, either fixed or dynamic obstruction within the LVOT. It can be that there is valve dysfunction, which can happen early or late and can be related to problems within the valve, Holt syndrome, thrombosis of the valve, malfunction within mechanical valves, and early valve failure. It can also be due to surgical considerations. There are a proportion of people in whom the high gradient is actually not reflective of the true obstructive nature of the valve. And this is particularly true in those people that have a small aorta, who tend to have a high gradient. And we can account for this by in a mathematical way and account for the pressure recovery phenomenon, but we don't often do that. And finally, the valve can be too small for the patient, or indeed the patient can be too big for the valve, resulting in patient prosthesis mismatch. So as I said, assumptions about orify and pressure gradients don't actually work that well, or at least easy assumptions don't. This is a standard valve, and there are a variety of different numbers that can fly out of this: the external diameter, the internal diameter, and the geometric orifice area, the true measured orifice area. But the gradient as a result of that can be very different. And as can the valve area. So part of that, for instance, is because of this phenomenon, the pressure recovery in patients, particularly those with smaller aortas, the gradient is up, it goes up quite fast, but the pressure is recovered rapidly in the ascending aorta, and therefore the consequences of that high velocity measured by Doppler are not the same, and you see different results when you do invasively measured pressures. Now, this is something that we can account for in the echo lab, but we actually rarely do, and this is probably something we could raise our game over. The second, and I think a really important point, is that the geometric orifice area, this purple splodge on the diagram, is not the same as the effective orifice area as measured by Doppler. Things such as the shape of the valve, the shape of the LVOT, and particularly the flow can result in a different effective orifice area to a geometric orifice area. And it is, of course, the effective orifice area which is critical to outcome. So, if you look at this, where you have a fairly abrupt change in dimension and high flow, you almost get this focusing effect. So the effective orifice area downstream of the geometric orifice area is smaller, and therefore the net effect is more obstructive. What does this mean? Well, it means that in reality, the effective orifice area and the obstructive nature of the valve are really quite difficult to define. So this is an example where you have a 23 millimeter perimount valve, and you can see that the measured effective orifice area by Doppler is really various, going from the very obstructive here below the severe threshold for patient prosthesis mismatch of 0.6 centimeters squared per meter squared, through to very big orifice areas. And this is with a normally functioning valve. So this is just as a result of all the factors that I described earlier. And similarly, although there is this very clear curvilinear relationship between index to orifice area and valve gradients with this kind of mismatch line at 0.85, you can see that for a given indexed area, you get a huge variety of gradients. So it's probably safe to say that there's a huge amount of variability, and easy assumptions regarding both orifice area and gradient should not be undertaken. And a variety of these are because of variations in technique, variations in aortic diameter, and these affect both the gradient and also the orifice area. So coming to the specific issue of patient prosthesis mismatch. Now, this is something which over the years people have debated backwards and forwards, and there's a vast data, and I wouldn't expect you even to be able to read the forest plot on the right. But what you can see is, because there is a large literature and they're mostly in small studies, this is the ideal situation for a meta-analysis. And there are a huge amount of meta-analyses out there. This is but one example, but they all show a consistent message that whether you're looking at early, midterm, or late mortality, that patient prosthesis mismatch, by which you mean either at least moderate, so 0.85 per meter squared, and definitely severe at 0.6 to 0.65 per meter squared, results in an adverse prognosis at each of those time points. Now, we've got a fantastic natural experiment, or unnatural experiment perhaps, to explore this further, which is valve-in-valve TAVI. And there's a very consistent data set that shows that if the valve area is taken into the severe patient prosthesis mismatch range because of a TAVI inserted inside of a bioprosthesis, then this has an adverse reaction. And even more compelling is this data which you see here, which is what happens even over 12 months to mortality if you start off with patient prosthesis mismatch. There's a 100% virtually increase in mortality if you put a valve-in-valve TAVI into somebody that already has patient prosthesis mismatch. So this corroborates the surgical data, which basically tells you that low gradients are better than high gradients. What about the physiological consequences? Now, although the correlation is not that strong, there's a really good signal in the literature that you get less beneficial remodeling and less regression of hypertrophy if you're in a situation of patient prosthesis mismatch. And in this data, the amount your orifice area increases does relate to the change in your left ventricular mass. When we exercise these patients in the echo lab, you can see the gradients quite often fly up with exertion, and that's a really good marker, particularly when you're in an intermediate zone. And if you look objectively at the exercise function, so more than just asking somebody and doing an NYHA, in this case, looking at cardiopulmonary exercise testing, you can see that those patients with patient prosthesis mismatch have, on average, a serious reduction in their exercise capacity as measured objectively. So it makes sense to start planning for this before the operation. And this is an approach where you look at the patient, you look at the valve in front of you, and you try and match the two. For all the reasons that I described in the opening slides, actually this can only be a guide, and the idea that you're performing a really empirical approach here is probably an illusion. Nonetheless, the relationship between geometric orifice area and effective orifice area is there, and therefore you are able to work out where the sort of size of valve that is likely to put you into this red zone, into this patient prosthesis mismatch. Is particularly useful at the extremes. And in observational series, it has been definitely demonstrated by using this preoperatively to reduce the incidence of patient prosthesis mismatch. So I'm going to share with you a clinical case or a clinical conundrum, which I think illustrates some of these points quite nicely. So, sorry, excuse me, we've bounced forward a slide there. So this is a 28-year-old gentleman who presents in 2018 with severe breathlessness, bicuspid aortic valve with normal aortic dimensions and normal coronary anatomy. At the time of initial assessment, he's 57 kilograms with a height of 1.74 meters, giving a body surface area of 1.66 meters squared. His interventricular septum is 0.9 centimeters, suggesting no hypertrophy. His ejection fraction is normal. His peak gradient is 55 millimeters of mercury with an aortic valve area of 0.9. And as a result of the symptoms, he then goes forward for aortic valve surgery. Now, he has a 19 millimeters St. Jude's valve, which seems quite small, but the geometric orifice area there is 1.48 centimeters squared, and the predicted valve area per meter squared actually falls well outside of the patient prosthesis mismatch zone. He has a limited incision, and actually it makes a very rapid recovery. Unfortunately, we don't have the immediate post-op echocardiography, and that unfortunately is a repeated finding throughout the country, and something we should do something about. So he's really well for 2 years, but then represents with increasing breathlessness, and most recently is in NYHA 2 to 3 breathlessness. He's got a good anticoagulation control, but things have changed. So his weight has gone up to 78 kilograms, not by any means obese, and consequently his body surface area has gone up to 1.94 meters squared. The mean gradient across his valve is now 20 millimeters of mercury, and the effective orifice area is much closer to 1, with an indexed effective orifice area of 0.57, thus pushing him into the patient prosthesis mismatch zone. His interventricular septum remains the same, or if anything, slightly increased. Now, because all of this sits in a borderline zone, we undertook exercise evaluation, and this demonstrated that his exercise ability was significantly limited by breathlessness, and the mean gradient shot up from 20 to 50 millimeters of mercury, indicating the valve is really quite obstructive. His left ventricular reserve was good, but his VO2, which we do at the same time, was only 54% of predicted, suggesting that he has a very real and objective exercise deficit. He had a CT which showed effectively normal function. And as a result of that, we came up with the final diagnosis that, in fact, despite the lowish gradients, he had severe patient prosthesis mismatch, and he had very high inducible gradients with no wall thickness regression. Now, the management here initially is to try and get him to lose weight and get him back to his perioperative state. But there's also a further discussion now about whether he should have aortic root revision and the implantation of a larger mechanical valve. So I suppose the general point is case selection is really important, and the valve should be selected to fit the patient both clinically and geometrically. And in that, the likelihood of patient prosthesis mismatch is really important, and using predictive charts can be exceptionally helpful. But also the impact of patient prosthesis mismatch. This guy who has bicuspid aortic valve disease is going to require potentially a different surgical approach at this stage in his life than he is in this stage of his life. In making these considerations, there needs to be discussion about the risks of advanced techniques, which obviously potentially carry a slightly higher risk, and also considerations of valve durability. So in conclusion, and to draw some perhaps pragmatic decision-making points, I think we can say the following. High gradients after an aortic valve replacement are, in general, a bad thing. The precise impact, however, on an individual is difficult to predict. The surgical strategy should target, therefore, the lowest achievable gradient in an individual patient. And in trying to achieve this, pre-surgical consideration is vital. And in particular, what is the highest gradient that you could possibly accept for a given individual? Advanced techniques with aortoplasty, Ross, or homograft may be appropriate in selected cases where patient prosthesis mismatch would be a disaster, but not to forget that patients change, and particularly young patients. And we see a large number of people that have been intervened on in their 20s who have put on a lot of weight as they move into their 30s and 40s, and this has a real impact on the obstructivity of the valve. Consequently, valve selection is critical in the decision. And in understanding these diseases, it's really important to get that post-operative echocardiogram in, because it really helps you predict future problems. So thank you very much for your attention, and I look forward to discussing things further with Chris.
Guy, that was fantastic. Thoroughly enjoyed it.
Thanks, Chris.
Always concentrate on the patient and the diagnosis. And what you're telling us is we need to look further down the line. And it's not just what you do at the operation and making the diagnosis. So there's sort of a couple of things that I want to ask you. One is, do you think that we should actually be coming up with a minimum valve size for each patient?
I think that's a really great point, and I completely agree with that. And while, as I demonstrated in my talk, actually a lot of the assumptions about what you see, particularly in terms of effective orifice area, can be quite complex, to put in a geometric orifice area valve that you can already predict that will cause a degree of patient prosthesis mismatch, or may be at high risk should there be some change in the morphology, particularly weight gain, actually, which we see a lot of in younger patients. In that patient, then you should be avoiding it. So I completely agree with that point, that when making that assessment to match the prosthesis with the patient, I think you've really got to look at the patient, a little bit like Arnie. You've got to say, what do you look like now? What will you look like in 10 years' time? and this is particularly important in very small people, as demonstrated by the case that I showed, because I think it is, but in the young particularly, you see people who can be very slight when they're in their 20s, but they can be an awful lot heavier by the time they're in their 40s, and that makes a huge difference if you put in a small valve. So yeah, totally agree with you.
The other thing that I find quite difficult to work out is when people come for their 6-week post-op echo, they have a very dynamic, bouncy circulation. And the echo you see then is not the echo you see at 12 months. And I'm not sure whether the changes are due to changes in left ventricular remodeling, changes in a more stable circulation, or whether the changes are the valve, because you see the EOA change in 12 months, but it's not deterioration. How do you interpret that?
I think that there are a number of causes that sit in there. A lot of it is about the circulation, and I think, if you look at both the, if you like, the remodeling and ventricular function aspects that happen, that's going to change the gradients and that's going to change the EOA. But also the peripheral circulation, you see a lot of adaptation immediately, in the early post-operative period that has then readapted as you go further forward. So that early preoperative scan is really important as a benchmark. But I think the point that you're making, which I would agree with, is that actually, to really understand how a valve's functioning, you've got to look a little bit down the line. There are so many things that are changing in the circulation, and we don't know the effect of sort of low-grade early inflammation, maybe a little bit of very minor thrombotic change within the valve. There are an awful lot of things at play. Some of them are biological, some of them are technical, and some of them are flow function related. So, there is a vogue, isn't there, for putting in a valve and then saying you're fixed and sending people off with no further follow-up, which is, supported to some extent by the guidelines. But I think often you can end up in trouble because of that, because you don't really understand what that valve looks like until it's had time to bed down.
Guy, that is absolutely fantastic. Thank you very much indeed.
Thank you for the invitation.
To move us on now and ask Ruben Janganathan to speak to us about the intuitive valve. Ruben, over to you.
Thank you, Chris, and I would like to thank Edwards Life Sciences for the invitation to present on rapid deployment valves, the unrealized potentials. My conflicts of interest are I'm a proctor for Edwards Life Sciences. Over the last century, there's been huge development in the treatment of aortic valve disease, from the lobotomy by Tuffier in 1914 to the first implant of a polyurethane valve by Nina Braunwald in the 1960s. And then with the subsequent development of stentless and stented bioprosthesis, and till not that long ago, when Alan Cribier did a transcatheter valve for compassionate reasons. However, despite all these advances, there still remains 3 Achilles heels for aortic valve prosthesis. The first one being durability, which is related to structural valve deterioration. This paper, published in 2015 by Bourguignon and colleagues, demonstrates the probability of reoperation due to structural valve deterioration based on the patient's age and also the duration of implant. And from this graph here, you can see that someone age 65 and above will have about 15 to 20% risk of a reoperation due to SVD at about 20 years. The next Achilles heel is patient prosthesis mismatch. And this is important because it does affect survival in patients who have severe PPM, which is defined as less than 0.65 cm squared per meter squared, which was highlighted in this paper by Moti and colleagues, and also in other numerous publications. Also, and colleagues was also able to demonstrate that in patients who had severe PPM, and in his study, he defined it as less than 0.7 cm squared per meter squared, the risk of reintervention due to SVD was nearly 2-fold higher compared to patients who did not have structural valve deterioration. And finally, the last Achilles heel, which is becoming more aware amongst the surgeons, is the lack of standardization in terms of implanting an aortic valve prosthesis. This paper by Tabata and colleagues demonstrated that in his cohort of patients who had a valve implanted either by simple interrupted or non-everting using pledgeted sutures, there was a difference in terms of the hemodynamic performance of the valve. He looked at patients who had a size 19 and 21, and you can see that there is a difference in terms of the effective orifice area, but also the fact that in patients who had the valve stitching using non-everting pledgeted sutures, they were twice as likely to have a risk of patient prosthesis mismatch. Now, over the last 5 to 10 years, there's been developments in the surgical valves in terms of rapid deployment technology and also utilizing certain benefits from transcatheter therapy. Even more recently, there's been superior valve design with the VFit technology we see with the Inspirus Resilia, and possibility with the new Resilia technology, which could possibly translate to increased durability based on the limited evidence in animal model studies. From my experience using the intuitive valve over the last few years, I find that there's some realized benefits and unrealized benefits or potentials of this valve. Now, with regards to the realized benefits, one, I feel that this valve is easy to implant because it's reproducible and there's specific steps that you have to take. Two, I feel that the valve has superior hemodynamic data based on the recent publications, both from registry data and from post-CE mark data. The valve is very efficient in the sense that it reduces the time to implant, and it's also safe with no other added risk of prosthetic complications, apart from maybe a slightly higher risk of pacemakers. And on top of that, it can facilitate minimally invasive surgery. Now, when you look at the intuitive valve, there are simple 5 steps. The valve is excised in a standard fashion. 3 sutures are inserted into the nadae of the annulus, and then the valve is deployed, snared in position, and then inflated with balloon inflation. And depending on the valve size, either 4.5 or 5 ATM for 10 seconds. And this was also eluded in the Sutureless and Rapid Deployment International Registry. When you look in terms of the superior hemodynamics, I reviewed the evidence and I divided it into laboratory studies and then also what is there in observational data. And there are 2 very important papers based on lab testing. The first paper by Lee Song and colleagues, in which they implanted a size 21 intuitive valve in an aortic root model that was made from elastometric material and also a cadaver, and then compared that with a 21 Paramount Magna Ease. And looking at the diagram, the first most noticeable thing is that you can see the circular LVOT that is conferred by the intuitive valve, rather than the puckered appearance in the LVOT to a valve that is actually stitched in. And in this study, they also looked at the way you stitch the valve in using horizontal mattress with and without pledgets. And this is also mimicked in the cadaver model, which you can see in figure E at the bottom of the slide. And when they looked at the hemodynamic performance of the valve, the Intuitive Elite valve performed extremely well with the lowest gradients and the best effective orifice area. And not surprisingly, they were able to actually reiterate what Tabata and colleagues demonstrated by the techniques of implantation, in which the patients who had pledgets utilized had higher gradient and had less of an effective orifice area. The next paper by Sadri and colleagues measured the flows across a 23 intuitive valve implanted into a human cadaver model. And when you look at the diagram here, you can see straight away that the intuitive valve confers a circular LVOT. And also, not only that, when you look at the dimensions in the LVOT, it is far better compared to a standard valve. What's interesting, when you look at the flows across the aortic valve, it tends to be laminar across the whole systole period. When one looks at the evidence, and when I compared it looking at conventional bioprosthesis, the recent publication by Wallace and colleagues was very, very interesting. They looked at data from the Triton study, which was a safety and efficacy study of the intuitive valve in Europe, and then compared it with the Paramount Magna Ease post-CE mark study. And what they did was, with the 2 groups of patients, they did propensity analysis. And what they found was that the intuitive valve performed far superior compared to the conventional valve and had a much lower incidence of patient prosthesis mismatch. When you compare the data of the intuitive valve with the sutureless valves, This paper by our Italian colleagues, which was a very large series. They looked at 18 institutions, over 900 patients, and then they did propensity matching between patients who had intuitive versus perceval. And again, they found similar findings. They found that patients who had the intuitive valve had better gradients, but the benefit with the perceval was it was quicker to implant. And then finally, when you look at registry data, which gives us, what people do on an everyday basis, the Gary registry data, which was published by Stefan Einsmenger and colleagues back in 2018, provided a lot of information. He looked at all patients over a 4-year period between 2011 and 2015. It was over 20,000 patients in the conventional group and over 1,000 patients in the rapid deployment valve group. And what he did was then he did a further propensity analysis looking at 3 cohorts of patients with rapid deployment technology. The 3F enable, the Intuiti, and the Perceval. Just to note, the 3F enable is no longer in the market. But what was very interesting was you can see the performance of the Intuiti. The number of patients who had a mean gradient above 20 was less than 2% compared to the rest of the valves. There was no patients with more than moderate aortic incompetence, and they had the lowest incidence of pacemaker implants. I then decided to look at the safety and efficacy of the intuitive valve, and this paper by the Vienna group was the largest series to date that I could find, over 700 implants, close to a 10-year period. And what was very, very interesting was the technical success was close to 99%. They had about an 8 to 9% pacemaker rate, and they had about 1.1% severe paravalvular leak. The take-home message here was that when you look at the reoperation for non-SVD, basically for paravalvular leaks less than 30 days, was 1.1%. It was basically the same group of patients who had severe PVL underwent surgery. And going after 30 days, the risk of needing a reoperation due to non-SVD, mainly paravalvular leaks, was about 0.2% per patient per year. What I found very interesting that over this 9-year period, the risk of reoperation due to structural valve deterioration was about 0.1% per patient per year. Now, when I look at my personal experience, I got a 98% technical success, and my pacemaker implants were about half of that, close just under 4%. And I had about 1 patient who had mild paravalvular leak, which was about roughly 2%. I have not seen yet to date reoperations for SVD and non-SVD related complications. In terms of efficiency, there's about a 25 to 30 minute savings, both on cross clamp and pump time, based from data from our institution, as well as that from the Triton and Transform trial, which was both the safety and efficacy of the intuitive valve both in Europe and in the US respectively. And finally, what is the unrealized or possibly realized or unrealized benefits of the intuitive valve? And apart from it being used in complex cases such as mitral or tricuspid valve repairs, aortic work, redo surgery, and more recently in patients who have severe mitral endocalcification, one of the limitations is to use them in patients who have mitral valve replacement. In this example here, I thought I'll share was some of the tips and tricks that I do for patients undergoing mitral valve replacement. This is an 82-year-old gentleman who had poor LV and was admitted with ongoing heart failure symptoms. He had triple valve pathology with severe aortic stenosis and severe tricuspid and mitral regurgitation. You can see here in the fluoroscopy, his aortic valve is heavily calcified and not moving. And on the echocardiogram, he had both aortic incompetence and mitral regurgitation with a very restricted aortic valve. Using a video scope on opening the aorta, you can see a tri-leaflet calcified aortic valve. And looking to the LVOT, you can see the aortomitral curtain and the anterior mitral valve leaflet. Following excision, which you tend to do in the standard way, you can see the left and right trigons, and I wanted to show the tension in relationship to the aortomitral curtain and the anterior leaflet. Now, the valve is sized in a routine fashion, and it was initially sized to size 25 paramount magna E's. And then following that, I addressed the mitral valve. And because the patient had a restricted leaflet, and he was age 82, I proceeded to replace the mitral valve. But in here, you can see I left an extra cuff of tissue on the anterior mitral valve leaflet. And the idea was this to try and increase the depth of the aortomitral curtain, as you'll see later. A size 29 paramount magnet ease was implanted. And then I went back to address the aortic valve and I resized it. Now you would note that in the initial slide it was a size 25, but now it's a size 23. And that is because the intertrigonal distance is reduced. Now, the reason of leaving the cuff of the leaflet is of the anterior mitral valve was to increase the depth of the anterior mitral curtain. And this basically facilitates two things. One, it prevents the mitral valve prosthesis from encroaching or obstructing the LVOT. And also, the second thing, it allows safe deployment of the intuitive valve as it prevents the two prostheses from interacting with one another. Now, another trick you could use is when you size it again after the mitral valve implant, you see whether the sizer would actually encroach onto the mitral valve. If it is hitting it, that would most probably state that you should maybe avoid using the intuitive and just implant a conventional bioprosthesis. Now, another trick that I tend to do is the 3 Nerday sutures that are inserted, rather than inserting them below the annulus, I tend to insert them at the level of the annulus. This is sort of increasing the height of the implant, something similar to transcatheter valves to try and reduce pacemaker rates. Now, you can only do this provided the coronaries are set high. And then the valve is implanted in a standard fashion. And you can see here, the skirt of the deployed intuitive valve does not encroach on the mitral valve prosthesis. Both the right trigon is clear and the left trigon is clear. And this is the post-operative echo showing the mitral valve functioning very well. It's not encroaching into the LVOT. And a color Doppler which demonstrates that there is no paravalvular leak across the intuitive valve. And the post-operative gradients were very, very, very good. The mean gradient across the aortic valve was 12. There was no paravalvular leak, and there were very good gradients across the mitral and LVOT. Now, one of the other unrealized benefits of the intuitive valve is the recent concept of this blood residence time, which is being made more aware due to leaflet thrombosis on the transcatheter valves. When you compare in this study here, when they compared the blood residence time, i.e. the contact of blood with the leaflet tissue between surgical and transcatheter valves, you can see that there's a huge difference between the two. The blood residence time was significantly higher in a transcatheter valve compared to a surgical valve. And why is this important in the intuitive valve? Because when you look at the way the intuitive valve is implanted, the intuitive valve is implanted by preserving the interleaflet triangles. After an intuitive valve is implanted, you can always see the interleaflet triangles, which is something that you do not see when you implant a conventional valve because the sutures sort of plicate and crimp this area. And therefore, you're getting a smaller sinus of Valsalva compared to that of the intuitive. And I think this then translates to a much lower blood residence time, and therefore I think better leaflet function and possibly better durability. But only time will tell when we have data at 5, 10, and 15 years. So my final comments is that there is a proven track record for the intuitive in terms of the hemodynamic performance. It's a matter of time, I think, before we get long-term data looking at the durability of the intuitive valve, especially in terms of structural valve deterioration. It's important to accept the realized benefits, but more importantly, to appreciate the unrealized potentials of the intuitive valve, especially in complex cases, and also with regards to the benefits in preservation of the sinus of Valsalva in terms of durability. And finally, I'd like to end is that given the armamentarium of devices that are out there, I think it's really important to incorporate existing technology to create an ideal valve, especially the fact that our patients are living much longer going forward. I'd like to thank Edwards Lifesciences for the opportunity to present on rapid deployment valves at this meeting.
Ruben, that was great. Thoroughly enjoyed the whole presentation. I love Intuity. Great to hear about it. what you've presented is a lot of literature evidence for Intuity. What's your own experience? Because we find it very good. What is the experience in Belfast?
Thank you, Chris, and thank you for the question. My personal experience is, apart from the the savings in cardiac pulmonary bypass and cross-clamp times, one of the interesting things that I noticed in my practice was the hemodynamic performance of the valves when we came off bypass. Now, I'll get my anesthetist to fill the patient up, get the CVP to about 12, good blood pressure, but I was getting really good gradients, especially in the small aortic roots. So then I looked through my practice, looked at the small aortic roots, compare that with the similar size 19 Paramount Magna E's, and I found really good gradients. It was statistically significant, superior. And then I extended it and compared it with similar size transcatheter valves and small aortic roots. And not only did I find that they were comparable, in some cases they were superior to certain valve types.
But thank you very much indeed for that. Thoroughly enjoyed it. And now we're going to move on to the last talk that we've got, which is by a friend of mine, a colleague, Gianluca Lucchesi, and he's going to talk about the subtleties of patient choice, operation choice, valve choice, and the differences between them. So over to you, Gianluca.
Thank you, Chris, for the kind introduction, and many thanks to the organization for the invitation. The topic of my presentation is surgical aortic valve replacement, a new paradigm. This is St. Thomas Hospital in the central London, the place where I've got the privilege to work. These are my disclosures. Why a new paradigm? A paradigm is in general a theoretical framework of any kind. And if I think back when I was a medical student or junior resident in cardiac surgery, an aortic valve replacement was basically a single procedure. And the choice was down to the valve prosthesis type, mechanical versus tissue valve. Whereas nowadays the equation is much more complicated, including minimal invasive cardiac surgery, different type of prosthesis with new tissues, making the valves more durable, and also the sutureless prosthesis. But let's start with the minimal invasive approaches. Minimal invasive in cardiac surgery means mainly no full transection of the breastbone and faster patient's mobilization, lower perioperative morbidity and mortality with less blood loss, and lower postoperative atrial fibrillation, less wound pain, faster reconvalescence, improved cosmesis, and increased patient satisfaction. Many minimal invasive approaches to the aortic valve have been described over the years, but the most used are the upper hemisternotomy and the limited right anterior thoracotomy. Are these approaches different in terms of outcome? Basically not. There is not a significant superiority of one approach over the others, and the results of either approach are equivalent to full sternotomy in terms of outcome. If at all, the minimal invasive approaches are characterized by relatively longer cross-clamp time and bypass time. However, this meta-regression shows a very good 30 days survival with a significant mortality reduction in comparison to the data in 1995. There are always limitations in any systematic review. In this specific one, I think the significant heterogeneity detected in the operative parameters, including cross-clamp time, bypass time, is definitely a limitation, and might be due to a different patient's cohort characteristics and selection criteria amongst the studies. However, it might also reflect the variation in experience and expertise of different centers. Another important aspect is the different type of prosthesis. In the past, the decision making was pretty straightforward, guidelines recommending mechanical prosthesis in patients younger than 65 years old, biological prosthesis in patients older than 65 years old. But things have changed over the years to respond to the patient's need. And what has been introduced in the guidelines is the so-called gray area, where basically either prosthesis, mechanical or biological, is acceptable. But what do the patients prefer? If we look at this study published by the group of David Adams, patients younger than 50 years old are definitely preferring biological valves over the years. The results in this subgroup of patients are basically similar in terms of survival and rate of stroke between the two subgroup of patients, mechanical versus biological. Of course, the major bleeding complications are higher in the mechanical group as expected, whereas the reoperation rate is higher in the biological group as expected. It's quite interesting to note that the mortality post-bleeding is 7.5%, whereas the mortality post-reoperation is definitely lower, of 4.8%, and would say even lower in the experience in tertiary center if the patient doesn't have significant comorbidities apart from the redo cardiac operation. But the same trend toward the biological prosthesis is also confirmed in an even younger subgroup of patients, younger than 30 years old. And it's quite interesting to note that the outcomes, either in terms of survival or reoperation rate, are basically similar between the patients having undergone aortic valve replacement, mechanical versus biological. But what is the response to this increased need of biological valves with a potential better durability? The response comes from the technology and is the neuroresilient tissue. We know that the free aldehydes are the major limiter of tissue durability, and this calcification process is quite accelerated in the youngs. The resilient tissue is a different tissue characterized by two important steps. The first one is the stable capping, which permanently blocks the free aldehydes. And the second one is the glycerolization, which prevents further exposure to the aldehydes. The valve is a dry valve, ready to use. The first experimental model has been published in 2015, where the valve was tested in a sheep model. 25 millimeters valves have been implanted, perimount and perimount with resilient tissue, and followed up for 8 months. And basically the amount of calcification in the resilient tissue was significantly lower in comparison to the perimount valve, with significant lower mean transvalvular gradient in the resilient tissue group. The first clinical paper has been published recently in 2021, and basically shows excellent result of the resilient valve at 5 years. Of course, longer term follow-up, clinical follow-up is needed to prove the better long-term durability of these valves. Currently, over 800 patients have received the valve with resilient tissue, either in aortic, mitral, or pulmonary position. Apart from the specific tissue and the structure of the stent, that is basically a perimount manganese valve, an important aspect is the VFit technology, with basically a flexible stent and an expansion zone, which makes this valve very good for potential future valve-in-valve, allowing a significantly bigger TAVI valve in comparison to the current prosthesis with the same diameter. The last but not least aspect of the current surgical valve replacement is represented by the sutureless prosthesis. The enable valve is not anymore on the market. The two main prostheses are the Percival and the Intuitive Elite. Actually, this picture shows the old Intuitive valve, which was restyled in 2014, and the new Intuitive Elite has got basically a slightly different anchoring stenting. As clearly demonstrated in the literature, we know that increased close clamp time is associated with increased cardiovascular morbidity, mainly in the context of additional risk factors like the impaired left ventricular function, diabetes, or hypertension. And the implantation of the sutureless valve has made the cross-clamp time and bypass time significantly lower, mainly in the context of minimal invasive cardiac surgery. This is why this combination represents a perfect marriage for the minimal invasive approaches to the aortic valve. But also, this type of prostheses are very useful in the context of combined procedure. And it's important to note that the Intuitive valve is the only one that can be used in the context of an ascending aorta replacement, because the anchoring of the valve is at the intra-annular level and without any supravalvular support. But beyond the cross-clamp time and the bypass time, the association of sutureless valves with the minimal invasive cardiac surgery has significantly decreased the in-hospital mortality from 1.6% in 2005 up to 0.7% in 2013, as demonstrated by this STTS data. I found interesting this systematic review comparing the two type of rapid deployment valves currently on the market, and it's interesting to note that the Intuitive valve is characterized by lower rate of paravalvular leaks and transvalvular gradient with better hemodynamic, whereas the Percival valve is characterized by shorter cross-clamp time and bypass time. Quite surprising finding though, because most of the authors nowadays do use the Olenburg modification of Percival implantation technique, which basically makes the technique of implantation very similar to an Intuitive valve implantation. The limitations of this analysis are the low level of evidence, the effect of the learning curve, but also a limited long-term data. Of course, this last statement does not apply to the Intuitive valve, because it's basically a perimount magnetic valve mounted in a different stent. The Achilles heel of the rapid deployment valves is represented by a relatively high permanent pacemaker implantation rate. This is a quite consistent finding in the literature, although might be related with and not appropriate sizing and with the first experience with the sutureless valves, but still is pretty consistent finding. Sometimes also the level of implantation might affect the rate of permanent pacemaker, and also the self-expandable valves seem worse than balloon expandable. However, I found this paper of the Professor Diosanio group very interesting, and showing objectively how the rapid deployment valves are not really associated with an increased pacemaker implantation rate, but more with an increased postoperative left bundle branch block. That, of course, in the context of preoperative rhythm disturbances, like the first degree heavy block or the right bundle branch block, might cause an increased rate of postoperative pacemaker, permanent pacemaker implantation. Also, it's important to note how the utilization of the sutureless valves does not affect survival or freedom from rehospitalization from cardiac events. So this is my algorithm when I do approach patients requiring an aortic valve implantation. My default approach to an aortic valve replacement is via minimally invasive approach, limited right anterior thoracotomy if no anatomical contraindications or contraindications to the fem-fem bypass, otherwise upper hemisternotomy. Then the decision goes down to the type of prosthesis, mechanical versus tissue valve, or Ross operation if the patient is pretty young and we need to consider a significant advantage in the survival. If the patient is younger than 65 years old and is not happy with a mechanical valve, definitely an Inspiris Resilia would be my preferred option. Otherwise, if the patient is happy with the tissue valve, the sutureless valve would be my default option. If a sutureless valve is contraindicated, I would go for a standard tissue prosthesis.
Gianluca, as ever, that was very enjoyable. Lovely to hear your thoughts on things. And I loved your algorithm at the end. And in your algorithm, you start with anterior right thoracotomy. And if you can't do it, you move on to upper hemisternotomy. Tell me why that is. Why do you prefer that?
I don't really prefer one approach over the other. It's just my standard approach. All the patients undergo a CT scan, and based on anatomical measurements, suitability for peripheral cardiopulmonary bypass, I just decided the approach, but I do think they are both equivalent in terms of outcome and aesthetic and cosmetic result.
What is the sort of take-home message for you?
Well, the take-home message is that does not exist anymore a standardized approach to an aortic valve replacement, but has to be tailored according to the patient's specific condition and needs. So I think nowadays an aortic valve replacement is not anymore just a valve. It needs to take into consideration specific surgical approach, specific patient's need, quality of life, and also their psychological approach to a possible reoperation, which is quite important bit.
Gianluca, that was such a mature answer. Thank you so much. It is not so simple as we thought. And this whole last hour has been about subtleties. We tend as surgeons to take aortic stenosis and put in a valve that fits. And Guy has challenged us that we should really be putting in a valve that the patient needs, not the one that's easiest for us to do, that we should be looking down the line into the future, acknowledging that patients will put on weight as they get older, acknowledging that there can be a problem with patient prosthesis mismatch at a later date, perhaps depriving people of a future TAVI by putting in too small a device. And what we've heard from Ruben is that Intuity is performing fantastically. And in the small aortic route, it is probably the ideal valve substitute. And then you have to go back to Guy and say, but this is a small aortic route. You may be denying patients a TAVI in the future. So you need to pick the right patient population to be getting that Intuity device. And then finally, as Gianluca has told us, this is not just a case of it's young, give it a mechanical, it's old, give it a tissue. This is actually much more complicated. And I think that's where the modern MDT is so important. We're starting to pick which incision, which device, should we be enlarging a root? How are we going to get the best holistically for this patient for the next 20 years, for the rest of their life? There's been a lot of subtleties brought up here. I've thoroughly enjoyed it. I hope you have too. Thank you very much.